Okay, we're now talking about the second step of the nursing process, which is nursing diagnosis. So when we talk about nursing diagnosis, it's important to understand that all the information that you collected, the data about your patient, both subjective and objective, your cues, your inferences, all of that stuff has to be valid, or your nursing diagnosis will not be valid. That's why we check and double check to make sure our data is accurate. So diagnosing is the activities preceding the diagnosis phase are directed toward forming the nursing diagnosis. All the steps after this flow from diagnosis. Critical thinking is vitally important because your assessment data, you're using that, it has to be correct, and you have to figure out what are my client's strengths, and also what's the problem, or what are the problems that we're going to focus on from a nursing perspective. Now, nursing diagnosis and nursing process has a language, and that language is called NANDA, and that's the North American Nursing Diagnosis Association International, and that is the language of nursing, and that's how we document things. Define, refine, and promote a taxonomy of nursing diagnostic terminology. So it's important to know that when you are writing a diagnosis, we don't just make up diagnoses in our head. We'll always have a label, and it's from a defined taxonomy, and that's simply a classification system or a set of categories arranged based on principles. But anytime you use a nursing diagnosis, we actually look up the label, and we're going to talk more about nursing diagnoses and actually how we put them together in a few minutes. So we are in the second step, diagnosis, and the things that happen in this step, go ahead, commit it to memory. We analyze data to identify your client or your patient's health problem, their risks and their strengths. So what's currently going on? What's a problem? What things are they at risk for? And then where are their areas of strength? And from that, we formulate a diagnostic statement. Diagnosing, the term simply refers to the reasoning process, and a diagnosis is a statement or conclusion regarding the nature of a phenomenon. The diagnostic label is the standardized NANDA name for diagnoses. If you flip through your Koser and Herbs books, you will find pages with diagnoses and explaining how they're applicable. You can also look at any care plan book, and on Moodle I'm going to post a page with some diagnoses that you can use in assignments. Some definitions you need to know: the etiology. The etiology is what causes a problem. What's the cause? It's the causal relationship between a problem and its related factors. So if your patient is having pain, why are they having pain? What is the cause of the pain? Nursing diagnosis is your problem statement consisting of your diagnostic label plus the etiology. So we're looking at nursing diagnosis, and we know that's our second step in the nursing process, and it's a clinical judgment that you will make. You might make it about an individual, a family, or a community, depending on how you're practicing, and it's a response, their response to an actual or potential health problem or life process. It's important to note we do not diagnose medical conditions because as a registered nurse, you are not licensed, it's not within your scope of practice to treat a medical condition, but we do treat their responses to that health problem. So nursing diagnosis, professional nurses, RNs, are responsible for making, and it includes only those health states that a nurse can treat, and judgments made only after a thorough systematic data collection that refers back to our assessment phase through a continuum of health states. That means basically from even pre-birth to death. So if we talk about the first type of diagnosis, that is an actual diagnosis. That means a problem is present at the time of assessment. This is something that's actually going on with the patient at this time. They have a problem, and then they have the signs and symptoms, our subjective and objective data to back that up. Your patient may be in pain. They may have facial grimacing. They may be holding a pillow to an incision, bracing. They may tell you, I'm having pain. 6 out of 10 on the pain scale. So it is a real problem. Our second type of nursing diagnosis is a health promotion diagnosis, and that really just is preparedness to implement behaviors to improve their health condition. So they're at a spot where they want to improve. They're already probably a healthy person, but they want to have a higher level of wellness. Unfortunately, in most clinical settings, this is not going to be our priority because there is a problem going on, or at least a risk going on. An example of this is readiness for enhanced nutrition. Anytime you see readiness for, that generally means you're dealing with a health promotion diagnosis. When you get into other courses, particularly into population health, this is where you will see these type of diagnoses. The status of the nursing diagnosis, we also have a risk nursing diagnosis, and that's our third kind of nursing diagnosis. So we've talked about an actual diagnosis, a health promotion diagnosis, and now we're looking at an at-risk diagnosis. That means your patient does not have this problem at this given moment, but they have a presence of risk factors that make it highly likely this problem will develop unless the nurse does something to stop this problem from developing. So it's a clinical judgment that a problem does not exist, but the presence of risk factors indicates it's very likely to develop. You identify when a patient could be at risk for additional health problems. Some common things that you might see: falls, risk for falls. Many things make us risk for falls. Advanced age. Think about being in the hospital. Think about all the medications that are administered. A lot of them can alter your mental status, make you sleepy, make you weak. Most patients in the hospital have an IV. They're connected to an IV pole. In the simple fact, you could be a very healthy young person, but trying to navigate to the bathroom, maybe in the middle of the night with an IV pole, that could put you at risk for falls. Another one that's common is aspiration. If you have a patient that has difficulty swallowing, they do not have a gag reflex, they're having NG tube feedings, they're at risk for aspiration. And that means that either whether it's falls, aspiration, or whatever it may be, skin integrity, maybe they're at risk to have breakdown, the nurse is going to implement interventions so that does not occur. And then our next type of nursing diagnosis is our syndrome diagnosis. Syndrome diagnoses is a cluster of nursing diagnoses that have similar interventions. So it's a cluster of nursing diagnoses that go together. Syndromes determine symptoms based on certain situations. We don't see these a lot, but some of the most common ones you may see are things like post-trauma syndrome, cluster of nursing diagnoses that go along with someone who's experienced great trauma. Relocation stress syndrome for someone that's moving to a new area. Disuse syndrome. Someone may be short of breath, maybe they have decreased oxygen, obesity, but for some reason they're not moving, or they're not moving a specific body part. Now we're going to talk about the components of a NANDA nursing diagnosis. The very first step is the problem, or the diagnostic label and definition. And this diagnostic label describes the client's health problem or response. And sometimes it requires specification. Sometimes we add words to give it more meaning, such as deficit or decreased, ineffective, or compromised. This problem diagnostic label, also called a NANDA, that's the first step of the nursing diagnosis. That's the first thing you will write down. And remember, you don't write this down out of your head. There are approved lists that come out every year with these nursing diagnoses on them, and one will be posted in Moodle for you to look at. But an example of this would be like deficit fluid volume, impaired urinary elimination. So you can easily see, you have to know what the problem is and what the priority is to be able to come up with this label. Okay, the next step is the etiology. So we already have the label. Let's say we're going with deficit fluid volume. The etiology is what's causing this deficit fluid problem. Identifies one or more probable causes of the health problem and gives direction to the required nursing therapy, enables the nurse to individualize the client's care. So if we know that our patient has deficit fluid volume, what could possibly be the cause of that? One possible cause is inadequate fluid intake. So if that's what's going on with your patient, they refuse to drink. So we have deficit fluid volume being our label, and we always connect these two statements with a related to, R/T. Deficit fluid volume related to the etiology, inadequate fluid intake. So our NANDA statement to this point, two parts, deficit fluid volume related to inadequate fluid intake. We could also have someone that we said's in pain. They're in acute pain. That's their label, acute pain. What's the etiology? Why are they in pain? Related to possibly an abdominal incision? So you can see for every patient it's going to be a little different, because while a lot of people might have acute pain, we know that that's going to be very specific and individualized to our patient because we know it's from an abdominal incision. And our third step of the nursing process is the defining characteristics. So we have our label, we have our etiology, and now we have a defining characteristics, and that's that data you collected in the assessment phase. That's the cluster of existing signs and symptoms that indicates an actual diagnosis. The client has to have the signs and symptoms if it's an actual diagnosis. So it's a cluster of factors that causes the client to be more vulnerable to a problem. That would be a risk 4. Or it's actual subjective and objective data stating the problem exists. So let me go ahead and further clarify. 1, we have an actual diagnosis where you have signs and symptoms. They're present, you see them. They have pain, they have the facial grimacing, they have the bracing, they have their rating of the pain, and their description of the pain. And then let's say we have a patient that's, let's say they're diabetic. They have peripheral neuropathy, they have poor feeling in their lower extremities. We know that that patient might be at risk for some type of skin integrity problem. But at this moment, there's not a problem. So at this point, you wouldn't have the signs and symptoms. So that would indicate that's a risk for diagnosis because there's no subjective or objective data that exists at the present time. So now we're going to differentiate a nursing diagnosis from a medical diagnosis. When we look at a nursing diagnosis, it's a statement of the nurse's judgment based on education, experience, expertise, and we have a license to treat. It describes the human's response, the client's physical, sociocultural, psychological, and spiritual response to an illness or health problem. Now, nursing diagnoses, they tend to change frequently. They change frequently as some problems are resolved, as they develop other problems, and their responses change. So they change when a client's responses change. It's an independent nursing function. It's an area of healthcare that is unique to nursing. It's separate and distinct from medical management. Medical diagnoses are different. They're made by a physician or an advanced practice nurse, and they refer to a disease process. Medicine is always looking at a disease process, and it remains the same as long as the disease process is present. It doesn't change frequently. And dependent nursing functions, physicians prescribe therapies and treatments. And when I say dependent, that means you are dependent on a physician or an advanced practice nurse to be able to implement a therapy because you need a nursing order to implement it. Independent nursing interventions are things that you can do all by yourself with no orders or clarification from anyone else. So if we're going to talk about dependent, orders for treatment, we don't arbitrarily give medication. It's not within our scope. We need an order. We don't arbitrarily put catheters in. We need an order. We don't initiate IV fluid. Wound care. Physicians prescribe mandated types of wound care. We follow an order to do that. We use both independent and dependent interventions. Independent, you do it alone. Dependent, you do it with a physician prescribing something. It requires monitoring of the client's conditions and preventions of potential complications. And nursing diagnoses occur when a particular disease or treatment is present. So collaborative problems are complications from a disease, test, or treatment that nurses cannot treat independently. So anytime you're working together with a physician or a healthcare provider, if a problem needs medication to resolve, the nurse cannot prescribe medication, so it's collaborative. So anytime you are implementing an intervention that you need a order to implement, we term that a collaborative problem. Okay, this slide is table 12.3 out of your Kozer and Herbst textbook, and it gives you an example of a nursing diagnosis, a medical diagnosis, and a collaborative problem. An example is a nursing diagnosis. We might have activity intolerance related to decreased cardiac output. That medical diagnosis could be myocardial infarction. A collaborative problem, potential complication of myocardial infarction could be congestive heart failure. That is a potential complication. That's something we're looking for, but not something we can treat independently, so it's collaborative. Now, a nursing diagnosis, you have your definition of a nursing diagnosis, a medical diagnosis, and of a collaborative problem. You have the orientation and responsibility for diagnosing, what the nursing focus is, what the medical focus is, and then for collaborative problems, the same. I'm not going to read this whole page to you, but go through, look at this, and make sure you truly understand the difference between a nursing diagnosis and a medical diagnosis. Now, when we look at the diagnostic process, you will use critical thinking. That key term will never go away. Critical thinking, reviewing data, and considering explanations before forming opinions. We analyze, we separate into components. That's the type of deductive reasoning. Separating it into the components, that might be subjective, objective data. And then we synthesize, we put it back together to form a whole. That refers to inductive reasoning. We also compare data with standards. Standards are norms, what's generally accepted, a measure, a rule, a model, or a pattern. And how do you know if your patient's pulse rate is within a normal range? Well, you look up that information against a standard to find out what's deemed to be within a defined limit. You also look at cues to consider significant. Remember, cues, that's our data we gather, subjective, objective data. If it points to negative, it can be pointing to something negative. It can point to something, a positive change in the client's health status, because at the end of the day, we want patients to improve. We might have something negative that varies from the norm and maybe could indicate some type of developmental delay. So be careful when you look at your cues and then make an inference from these cues. What does it mean? So we analyze the data. Our next step is clustering the cues, determine the relatedness of facts, and inductively or with a framework. So we're identifying gaps and inconsistencies in data. You're looking to see, do you have conflicting data? Does your subjective and objective information, do they agree? All inconsistencies must be clarified. If you do not clarify an inconsistency, your nursing diagnosis will be incorrect. All inconsistencies, clarify it before a valid pattern can be established. And you are making a pattern. You're seeing what your patient's pattern is. This slide is table 12.4 out of your Kozer and Herbst book. And it looks at client cues that you may discover, subjective and objective data, and then the standard or norm. The first type of cue is deviation from a normal population. We have the height and the weight for a female patient. We can look at height and weight tables to see if this is ideal. And then we have a different type of cue, which could be a developmental delay. If you're working with children, if a child is 17 months old and they haven't started speaking, we know that's a delay because they generally speak their worst words by 10 to 12 months of age. And right now you may not know that, but that's something you could look up. Change in client's usual health status. If someone states something's changing, I'm just not hungry these days, and their intake changes, we can see that that's a negative change. We have dysfunctional behavior. It's another type of cue. And then changes in clients' usual behavior or their health status. We also identify health problems, risks, and strengths. We determine the problems and the risks, problems that support the tentative or actual risk and possible diagnoses, and we determine whether a problem is a nursing problem. Can we handle it independently? Is it a medical diagnosis or a collaborative problem that we're going to work with a physician on? We also determine your patient's strengths, their resources, their abilities to cope, And that can really be helpful to mobilize health in the regenerative process. We're always going to draw on someone's strengths. And that can include things like their home life, their educational background, what they do for recreation or exercise, their work, their family and friends, religious beliefs, and a sense of humor when appropriate. Okay, this slide is figure 12.2, and this is simply a type of map to guide you in the process. The first thing you're going to do is have identification of a significant cue cluster, or problems, another way of saying problem. The next question you ask yourself is, can the nurse take independent action to prevent or treat the problem? If the answer is yes, are these the primary interventions needed to achieve the goal? If the answer is yes, it's a nursing diagnosis. If it's a no, are both medical and nursing orders needed to prevent or treat the problem? If it's yes, it's a collaborative problem. But if you're no all the way through this process, that refers to a medical diagnosis. Remember, we don't treat medical diagnosis, we treat the response to problems. So we have different types of problems. Basic two-part problem is your problem, remember that's the label, plus your etiology. Remember, the etiology is what's the cause, and it's always joined by the words related to. And we add words if the NANDA label contains the word specify. So we could go back to our example and say deficit fluid volume related to inadequate intake being the etiology. We also have a basic three-part statement, which can be referred to as PES format, and that's problem, etiology, signs and symptoms. So you have your problem, it's your label, your NANDA, you have your etiology, and that's your cause, and then you have your signs and symptoms, your subjective and objective data. This is really recommended for any beginning diagnostician. Now, you are considered a beginning diagnostician, probably a label you never knew you'd have. So you're going to list the signs and symptoms grouped by subjective and objective data. So an example of this is, let's go back to deficit fluid volume, that's our label. Related to inadequate intake, that's our etiology. Now when we move into the next step, that signs and symptoms, we will write as evidenced by or as manifested by. So you're either going to have AEB or AMB, the initials. So deficit fluid volume related to an inadequate intake as evidenced by or as manifested by dry mucous membranes and concentrated urine. That's their signs and symptoms. That is a three-part diagnostic statement, and generally when you're writing these for care plans, that's exactly what's going to be asked for. Now let's deviate for a second and let's remember our potential diagnosis, our at-risk diagnosis, something they're at risk for. These will never have signs and symptoms for something that's occurring because it's not occurring. For signs and symptoms, you can risk what their factors are, why this could be a potential problem. We also have one-part statements, and we use these in health promotion diagnoses and in syndrome diagnoses, and there's 7 predominant syndrome diagnoses that I will not ask you to know about because if you need this information, you can always look it up. But remember, our health promotion diagnoses generally begin with readiness for enhanced. We also have variations of the basic format where you have an unknown etiology. So you have defining characteristics present, but you don't know what the cause is. We can also have complex factors when there's too many known causes to briefly state. And then we have possible, and that's either a problem or an etiology. And then we have the secondary to. Secondary to is an important part because it can divide the etiology into 2 parts. So if we're going to say something is secondary to, we might say someone has impaired swallowing, so they can't swallow or they don't swallow effectively, related to maybe it's neuromuscular involvement, but we want to add more to that etiology. Now, one cardinal rule of nursing diagnoses is our etiology should never be a medical diagnosis because we are not licensed to treat medical diagnoses. So the way we get around this is we need another nursing professional to understand that their impaired swallowing is related to a neuromuscular involvement, more specifically exactly what occurred. So we say impaired swallowing related to neuromuscular involvement secondary to a cerebrovascular accident. That is how we can interject a medical diagnosis inside of a nursing diagnosis, by saying secondary to. Another example is impaired physical mobility, and that might be related to muscle rigidity and tremor secondary to Parkinson's, as evidenced by a limited range of motion or movement. Then we have collaborative problems, and collaborative problems always begin with potential complications, PC. Etiology may be useful in some situations. In evaluating the quality of the diagnostic statement, we're going to validate with the clients and compare the signs and symptoms to NANDA defining characteristics. So we're looking at potential complications. Now this is table 12.6, and this is guidelines for writing a nursing diagnostic statement. And this is really a page you should just copy, keep it with you in your notebook anytime you're in clinical or you're thinking about writing a diagnosis. You always state it in terms of a problem, not a need. Deficit fluid problem is a problem related to fever. Now, if we said fluid replacement, that's a need. That's something we're going to do as an intervention. So that would be an incorrect or ambiguous statement. We're going to word the statement so it's legally advisable. Impaired skin integrity related to immobility is legally acceptable. Now, if we were to say someone had impaired skin integrity, so we're saying they probably have a wound or skin breakdown related to improper positioning, well, who positions the clients? Generally the nurses, the nursing assistants. So that really implies legal liability. They really could have come into the hospital with skin breakdown that had nothing to do with our positioning. So what is it really related to? It's related to the fact that they can't move themselves and they're immobile. We use non-judgmental statements. Spiritual distress related to inability to attend church services secondary to immobility, that's very non-judgmental. But if we said spiritual stress related to strict rules necessitating church attendance, we're putting a judgment on that. We're also going to make sure that both elements of the statement do not say the same thing. Risk for impaired skin integrity related to immobility, that is saying two different things. But if we say that someone has impaired skin integrity related to ulcerations of the sacral area, that response and probable cause are exactly the same thing. We might have impaired skin integrity related to immobility, and then as evidenced by ulceration of the sacral area. We're also going to be sure that the cause and effect are clearly stated, meaning the etiology is the cause of the problem or puts the client at risk for the problem. And a correct example is severe headache related to avoidance of narcotics due to fear of addiction. But if we said pain related to severe headache, we're saying exactly the same thing, pain related to pain. We're going to word the diagnosis specifically and precisely to provide directions for planning our nursing interventions. Impaired oral mucous membranes related to decreased salivation secondary to radiation of the neck. That's very specific. That's correct. But if we said impaired oral mucous membranes related to noxious agent, what is the noxious agent? You might know, but do other nurses know? Coming on shift, reading what you've written. We use nursing terminology rather than medical terminologies to describe the client's response. Risk for ineffective airway secretions related to accumulations of secretions in the lungs. But if we said risk for pneumonia, that's medical terminology. That's not something that we treat. The only way we're going to use a medical diagnosis is if we put it in the etiology as a secondary to. And then we use nursing terminology. We said that. Use nursing terminology rather than medical terminology to describe the probable cause of the client's conditions. Remember, that's secondary to. Same thing with number 7 to describe the client's response. There are some errors we can make in diagnostic reasoning, building this nursing process. 1, we have to verify data. Need to build a good knowledge base and acquire clinical experience. So is your data correct? Do you have the knowledge base? Right now you may not, so might be verifying an awful lot and looking up an awful lot of things. You need a working knowledge of what is considered to be normal within a defined limit. These are the things that you have learned in health assessment or you are learning now. You will consult resources because no one knows every single answer. And you're going to base your diagnosis on patterns rather than an isolated incident. And every time that you build a nursing diagnosis, you are improving your ability to critically think. So as we wrap this up, there's a process for accepting new and modified labels, and they're reviewed biannually by NANDA, the North American Nursing Diagnosis Association. It's the development of a standardized nursing language. We have nursing language that includes nursing diagnoses, nursing interventions, and nursing outcomes. And there's also a nursing minimum data set for computerized records. So NANDA is all-inclusive. It is the language of nursing. It is something you have to learn, because to be a registered nurse is to be able to speak the language of nursing. So please review nursing diagnoses, know the different types of diagnoses, but know that when you get into the clinical setting, you will mainly be using actual diagnoses and risk-for diagnoses, and you will be using 3-part diagnoses. And remember, if we just recap, that's going to be your label, your NANDA, related to your etiology, as evidenced by your signs and symptoms. Thank you.